This is Going Under, Anesthesia Answered with Dr. Brian Schmutzler. I'm your host, Fahid Sadrzadeh, and here is Dr. Brian Schmutzler, who has over 2 decades of medical and anesthesia experience. Last episode, we talked about your salary, but you didn't talk about it at all, so thanks so much for giving us perspective, though, as to the range of what physicians can make in your practice. And along those lines, today's topic is going to focus on, I'd like to call it different pathways for anesthesiologists, but it's kind of the different practices you can go, the different routes you can go off into while practicing anesthesia.
Yeah. So we talked a little bit about this last time. Because of the supply and demand issues in anesthesia, the probably the biggest practice type right now is locum tenens, which just basically means part-time as-needed work. You find either a company or a hospital or something that needs somebody to fill in some gaps, and you go and they pay you for that work time, and you go in, you get your work done, and you leave. And really, you're not invested in that practice. It's really just, similar to, I think people understand, like travel nursing or, just as needed work, right? Even say, seasonal work, right? So you go to Home Goods or whatever, and you say, hey, it's Christmas time. I know you need extra people. I'll come work. So that's the biggest thing happening right now. And we talked a little bit about this last time, that it's 2 or 3 times the compensation of a lot of the other models, which is good and bad. I mean, I think particularly in anesthesia, the move toward locum tenens is going to put a lot of facilities out of business. And this is sort of doom and gloom, but this is something we talk about a lot in anesthesia, is if everybody's making 2 or 3 times what the average person who has a full-time job is making, then you've just pushed the market higher, right? So that's great in the short term for anesthesiologists and CRNAs, but not so great in the long term, because if we're not getting reimbursed anywhere near what we're getting paid, the hospitals are eating the difference, or the surgery centers or whatever are eating the difference. And eventually that's going to put a lot of hospitals out of business. So particularly hospitals that take primarily Medicare and Medicaid.
Brian, so along those lines of locum tenens, you said this has taken off ever since COVID,
right? Because
of the lack of providers and kind of what happened during COVID. Do you think this is the future of medicine?
Yeah, I mean, I think it's a short-term future, but I think the big problem with locum tenens, and we may have addressed this from time to time before, locum tenens make 2 or 3 times what a full-time provider makes. And in doing that, not only is it a short-term problem for the hospitals, but it's increasing that base salary for other anesthesia providers as well, which is great in the short term. But the problem is we're not getting reimbursed anymore from the insurance companies or from Medicare and Medicaid. And so there's a shortfall there. The hospitals, surgery centers, whatever, are going to have to make up that shortfall. And eventually, in my opinion, that's going to drive a lot of these hospitals out of business. The hospitals already run it on really thin margins, and now you're dropping millions of dollars into anesthesia to keep up with the locums market. So we're already seeing it happen in some ways. We were on this trajectory from, let's say, probably June of 2021 till now, or till maybe 3-4 months ago, where the locum tenens rates were just skyrocketing. We're kind of coming to the top of the curve now. They're still going up, but they're not skyrocketing like they were. And what a lot of hospitals are doing are just saying, I'll just shut down a room before I bring on another locum tenens provider, because it's just too expensive, and we're not making back the money that we're going to have to pay out. So, I think it's a good thing to do in transitions between jobs. Maybe if you're trying to figure out what you want to do for short periods of time, but to be a full-time locum tenens, I don't think is. In 3 to 5 years, I don't think that's going to really exist the way that it does now. So anyway, so that's kind of the first practice type that you can do. The next thing I think of is private practice. So essentially what that means is you come out, you're an owner in the business. Usually it takes some time to get up to where you're actually an owner in the business, but you've got a group of physicians or CRNAs who come together, who do basically everything. They own the business. They, contract with hospitals or surgery centers or offices or physicians or whatever. And then, they run the practice themselves. That was big in the mid to late 90s, early 2000s, up almost really until COVID. When COVID hit, a lot of these private practices that were already sort of having issues with staffing and some financial issues really kind of crashed because no revenue during COVID. So the pendulum's really swung away from private practice and to one of three other models, and so we'll get into those as well. So private practice is, again, you have ownership in the practice. A lot of flexibility in that. The ability in the past, anyway, if you had good contracts, to make a lot of money and have ownership in something. And a lot of private equity-backed firms were then going in and buying those practices, and people were getting huge, 10, 12, 15 times EBITDA for those practices. And so that was great, 10, 12 years ago, but not really the way it is so much anymore. Then you've got employment, right? So where a hospital system or a hospital or a surgery center, often through its physician network, employs the providers themselves. And so you just get a salary, right? It's just like any other job. You say, hey, I'm supposed to work 2,100 hours a year. I get 6 weeks of vacation. They pay for my malpractice. They pay for all this kind of stuff. All of your benefits and all that sort of stuff. So you're not billing and collecting and looking at that and, the eat what you kill model, which private practice usually is, which is, hey, if I did 3 gallbladders today and each of those gallbladders paid $2,100, I'm going to get $6,300 from those gallbladders today. Now I got to pay my overhead, but that's what I earn for the day. Employment is literally just everybody else takes the risk. You essentially show up and get a paycheck. Then you've got the anesthesia management groups and anesthesia management companies and the anesthesia groups, big national organizations. In general, the difference is the anesthesia management groups tend to leave the practices alone and just take the business side away, right? So, I'm involved with CCI, which is a national anesthesia management company, and I'll talk a little bit about sort of the non-clinical things that anesthesiologists can do. But so I serve as Vice President of Medical Affairs for CCI Anesthesia. And CCI is great as a management company because they handle all the business end of things, but they don't go in and tell the practice how to practice, right? Unless there's significant clinical issues, the practice gets to remain sort of private practice or practicing on their own, while CCI handles all of the business end of things, billing, collecting, revenue cycle, dealing with the CEO of the hospital, all that sort of stuff. Then you've got your anesthesia groups, large national anesthesia groups, which are, again, and I won't go into any specifics, but these groups usually really direct practice across the country. And so they're going to standardize, hey, you work for Nuco Anesthesia LLC or whatever they're called, whether you work in, Denver, Colorado, Austin, Texas, Miami, Florida, or Indianapolis, Indiana, you're going to do the exact same thing. We have all these clinical pathways, all this sort of stuff. So there's a lot more control at the national level in those groups. They tend to pay a little bit less, but then again, essentially it's like being employed by a hospital in the sense that you don't have to deal with anything. You don't worry about, billing, collecting, any of that sort of stuff. A lot of times you get benefits. And so that's sort of the big ones. And then you've got academics. So that's the other kind of often left field type thing. Academics, a lot of times those are employed positions, and those are in academic medical centers where you're going to have residents and students and all that kind of stuff. And so you're doing a ton of teaching on top of doing anesthesia. So that's kind of the realm of clinical practice. And then did you have something you were going to ask?
No. Okay. Go ahead. Yeah, I'm actively listening here.
All right, fair enough. So then
a lot of different ways.
Then there's also a lot of ways that anesthesia providers can be in the non-clinical or administrative realm, and so I do some of this as well. I serve as medical director of the operating room or director of anesthesia services for several locations. Basically what this means is I look at policies, I look at procedures, sign collaborative agreements with CRNAs at these locations in states that require it, and then just kind of serve on the board of the hospital, the medical board of the hospital or the medical executive committee to kind of drive OR policy and anesthesia policy. And then, like I said, I'm the Vice President of Medical Affairs for CCI Anesthesia, where it's another administrative position where I sort of am in the medical affairs department where I handle all of the clinical aspects of the company. And so, if we have a bad patient outcome, I go in and I figure out what happened, kind of talk to the providers. All the chiefs report to me, chiefs at the sites report to me if they have an issue, that sort of stuff. So, and I think there's probably several other administrative responsibilities that anesthesiologists can take on. I mean, anesthesiologists can run practices in the private practice or even in the management or in the anesthesia management or larger anesthesia group world. There's a lot of different non-clinical paths that anesthesia providers take as well.
And how long did it take you to kind of get that freedom to make those decisions or do that, right? I mean, like automatically when you come out of med school or residency,
yeah.
Can you take this path when you leave residency, or like did it take you a while to get this kind of freedom to where you can make the decisions, hey, I want to do this, and kind of be an independent contractor as of sorts?
Yeah, so I don't think I probably could have come straight out of residency and gone into a leadership position, right?
Yeah.
Most places are looking for somebody who's got some leadership experience, and so for me that started kind of, I went into private practice to start with, and for me that started as being a leader within the hospital and within the practice itself, and then sort of turning that into leadership within a surgery center organization, and then leadership within an anesthesia management company, and then also showing leadership independently, which is, obviously, as we talked about, the staffing company that I'm a part of as well. So, that's probably not something that somebody straight out of residency is going to do, but you certainly can start getting yourself positioned to be in leadership roles within the organization that you're in.
You might have thought about it, but, as you kind of transition from OR full-time to kind of these leadership positions, what does the next 5 to 10 years hold, right? When you kind of look at the long term of anesthesia, maybe this is a multi-part question. Where do you see the future of anesthesia going? And 2, where is your future in anesthesia?
Yeah, that's tough. The future of anesthesia is really up in the air right now. Something's got to give on the supply demand and revenue cost aspects of things. We've got to create in some way, shape, or form more anesthesia providers because there's just not enough of us.
Why do you think that is? Why do you think that?
Well,
so it's a tough profession to get into, right? I mean,
it's not. I mean, it's not easy. None of these high-level professions are. But CMS, the Medicare and Medicaid, limit the number of anesthesia residencies, and so we have more anesthesiologists retiring than we're creating, because there's a limit, not because there isn't a desire for people to become anesthesiologists, but there's limited spots in residency. And the time period, right? So again, from the time you decide, even let's say at the end of undergrad, you say, I want to be an anesthesiologist, it's 8 years. You say you want to be a CRNA at the end of nursing school, it's another 2 plus 3, at least 5, sometimes more than that years, right? So, and they're same aspect in terms of CRNA schools. They're not funded by Medicare and Medicaid, but they're not enough of them either. We're not producing enough CRNAs either. And then obviously AAs, we've talked about briefly before, but there's not very many AA schools, and there's not very many states where they're actually licensed anyway. So that's a kind of a drop in the bucket when compared to the CRNAs and anesthesiologists, but we're just not creating enough of them to replace the number that are retiring. So that's the big part of the supply and demand issue. So, I mean, there's some easy fixes to that, right? I mean, some of the easy fixes are more funding from Medicare and Medicaid to create more anesthesia spots. And then, more funding from whatever source to create more CRNA spots. So those are kind of that realm of things. And then reimbursement versus cost. We got to get away from pure locums. It's just too expensive. And then, honestly, we need to lobby the federal government and whomever with these insurance companies to get our reimbursement back to a level that actually pays for the work that we do. Because right now, I think we've talked about this on some of our some of the reels that I've done, is we're undervalued when it comes to the amount per unit that we're reimbursed by Medicare, Medicaid, and the insurance companies.
So there's a lot of things at play here that could jeopardize the future of anesthesia.
Yeah, I mean,
or the profession of anesthesiologist.
The profession of anesthesia. Yeah. I mean, you're always going to need anesthesia, right? So there's always going to be a job out there, but what that's going to look like is kind of up in the air for anyone to tell. So,
And what about you for the next 5 to 10 years? What's the plan for Dr. Brian Schmutzler?
I mean, I'm staying the course for now. I'm clinical and administrative, and we're gonna continue on that route for a while and see where things go.
Now that you've done the kind of administrative for a little bit, how do you compare that to the clinical side of things? What obviously you're always going to be the doc, right? You know, going into the room and
right.
But how does the non-clinical side compare?
Yeah, I mean, I like that side of things. I feel like I have an aptitude for it, and I feel like a lot of my past experiences being not only medical school residency, doing a PhD, which kind of teaches you how to think and interact with people, and then having leadership roles set me up well to go into the administrative end of things. But a lot of it is putting out fires, just like putting out fires in the operating room, right? Not physical fires, but issues that come up. Same thing in the administrative end, right? There's always an issue that comes up. You've got to learn how to calmly take in the information, think about the issue quickly, and fix it. It's similar to the operating room, I think.
And you have the demeanor for it. I mean, you are a very calm person, even if it doesn't feel like it internally to you. Outwardly, you're a very calm person. So, I mean, I don't know if that's a natural demeanor of anesthesiologists. It's just
tends to be, yeah.
Very mild-mannered and calm.
I think the calmness is typical within anesthesia. I think a lot of my anesthesia colleagues, and not that this is any fault, but tend to be more introverted and like to kind of keep themselves. And I'm much more extroverted, so I feel like that makes me pretty good at interacting with administrators and other colleagues and professionals and stuff. So
I've seen you on social media. You're not that introverted.
Oh, wait, it's correct.
Follow him on social media, by the way. Shameless plug. Instagram, Facebook, YouTube, Patreon, if you want to learn more about some of those blocks. I know there's a lot of prospective students, medical students, and providers that watch and listen to the podcast and to your reels, and they're interested in some of that material. And it's just a good time to kind of speak about what those blocks are, Brian, quickly before we get to the questions,
sure.
and what you're teaching on there.
Yeah, sure. So I put a real emphasis in my career on regional anesthesia and ambulatory anesthesia, particularly the regional anesthesia end of things. And so the Patreon page includes teaching on actual live patients about all of these blocks. So upper extremity blocks, brachial plexus, trunk blocks, ESP, PECs, TAP, some of the other kind of lower level upper extremity blocks with the axillary blocks, lower extremity blocks, added canal, fascia iliaca, popliteal. So we go through a lot of those blocks, and I give quite a bit of tips and tricks. Something we're doing, offering at a lower cost than if you were to have to go to one of the seminars that I teach at. Leave home and travel somewhere. This is a nice way to be able to kind of purchase that and sit at home and figure things out. And then I answer questions on those as well. If anybody ever has a question, try to get to those pretty quickly as well. Dr.
Brian Schmutzler, that's on Patreon as well. So make sure you follow that page. And, of course, speaking of questions, we're going to get to the Q&A right now, the kind of rapid-fire part of our podcast, where Brian answers your questions that you put out there on all platforms. All right, Brian, question number 1. Can you talk about anesthesia used for thymectomy on teenage patients with
myasthenia gravis?
Oh, man, I wanted to say it.
Go ahead, try it.
Myasthenia gravis.
There you go, yeah. So, that's a fairly high-level procedure if you're actually doing a true thymectomy. A lot of times, depending on how large the thymus is, we actually have to, go into the chest. So a lot of times we have cardiovascular surgery on standby. We're ready to do a lot of things that oftentimes you don't actually need, but we have them there. So that's a pretty high level case. I don't do a lot of those anymore. Did several during residency and probably one or two since I've been a staff anesthesiologist. So I don't have a perfect perspective on that, but certainly. So there's a lot of things you have to consider. So number one, a patient who has myasthenia gravis responds differently to the anesthetics that we give, and so that's a big deal. We really have to tailor the anesthetic in a way that's not going to cause them to be paralyzed longer than we want them to be paralyzed, and also to wake up more smoothly. So that's part of it. So that's a patient consideration. You've got a procedural consideration. So if the thymus is real large, oftentimes when they lay flat, patient lays flat, they'll have a hard time breathing. It'll cut off the trachea, cut off the airway. And so there's quite a bit of testing we do ahead of time and questioning of the patient to figure out how we're actually going to get them to sleep and put the endotracheal tube in. So that's a sort of procedural consideration. And then we've got the whole consideration of the actual surgery itself. How do we take care of that patient during surgery, especially if we have to go into the chest, if there's any involvement in the cardiac system, and then you've got open heart procedure, you're going to have to do putting them on bypass and all kinds of stuff. So it's a complicated surgery. What I would say is if you're thinking about you said you had a teenager, so I'm assuming that's your either son or daughter, make sure you go to a center that does a lot of them, right? Because this is just like anything else. The more you do of it, the better you're going to be, right? So if you need a total knee done, you come to my hospital. We do thousands and thousands of them a year. You need a thymectomy done, you go to a center that does a lot of thymectomies.
All right. Our second question is, they always have difficulty finding my veins, especially after fasting minimum 8 hours.
Yep.
Any solution?
I don't have a great solution, but I have some suggestions. So number one, hydrate up until that 8 hours. Stay as hydrated as you possibly can. And then, tell them ahead of time. So honestly, what I do, patients who say, hey, I'm a tough, they say tough stick or tough IV. Patients who come in, they're tough stick, tough IV. I go straight to using the ultrasound. I can see a vein much better with an ultrasound than I can just kind of feeling around. The majority of anesthesia providers are pretty good with an ultrasound. So you just grab the ultrasound, throw the ultrasound on, put it in a vein, much easier that way. But what can you do? I mean, the two things you can do, hydrate and then tell your anesthesia provider that you're a tough IV and see if they can do some fancy things to make that more pleasant for you.
Can I just brag for 1 second
Sure,
here?
yeah.
For once, can I just kind of 1 second? Can I just say how good of a patient I was? I went to get my labs this week, and she was an amazing lab tech. Loved her. Went to the neighboring town here to the clinic, and she had to get some blood work, whatever. And she popped my left arm up, and my right arm is kind of difficult because I've got some tattoos. So
hard to see.
Yeah. The left arm is free and clear. So she went in the left arm, and immediately she was like, "Oh, awesome! I can see your veins." And I said, "My anesthesiologist told me to hydrate, and I had to fast before this thing.
Yeah, 8 hours before. Yeah."
And she's like, "Wow, I'm really, really impressed." I'm like, "Hey, you tell my anesthesiologist, because I learned this on the podcast.
There you go.
I learned this on the podcast. So
did you drop her listen to our podcast? Is it?
I did actually.
Okay, good.
She's like, "Where did you learn that?" And I, of course, bragged about
yourself. Oh, me.
No, about you.
Me.
Yeah,
okay,
about you.
Right. I thought you were bragging about yourself.
No, never. But I am proud of the fact that I
drinking the water. Yeah,
drank the water. All right, our final question. Actually, I have one more question, if I can remember it after this one.
Sure. Yeah.
But what are the guidelines for GLP1 inhibitors? Can you explain what those are?
Yeah, sure. So this is a huge hot topic in anesthesia right now. GLP1 inhibitors are a group of medications that were traditionally used for diabetes and now are being used pretty ubiquitously for weight loss. So those include medicines you guys have probably heard of: Ozempic, Wegovy, Saxenda, I think. Rybelsus is the oral form. And so the ASA, our governing body, came up with a guideline that patients should be off of the injectables like Ozempic and Wegovy for 1 week and the orals for a full 24 hours. Now, we've been following these guidelines for probably 6 months, 9 months, something like that. What we're finding as a profession and what I'm finding personally is these patients, even after being off a week from the injectables or a day from the orals, still have some food in their stomach from eating more than 8 hours ahead of time and have a ton of nausea. That's one of the side effects of these medications. The reason that people lose weight with them, partially it slows gastric emptying. So the food going from the stomach into the intestines is slower. So you feel fuller because of that. And then it probably also works in the gut and in the brain to make you feel full as well. So you just eat less, which is part of the reason you lose weight. It also, kind of regulates the blood glucose, which may help as well. So anyway, what we're finding is that even after being off the appropriate amount of time, according to the ASA, that these patients still have food in their stomach. And so there's some rumors that the guidelines are going to be expanded to longer. And at least in my clinical experience, I would support doing that, maybe even doubling the amount of time that these patients are off the medications.
I don't know if we want to go down the Ozempic rabbit hole because it's, it could be a whole topic for a whole day.
We can pick a podcast about it.
And obviously it doesn't really have much to do with anesthesia, but it's just interesting, right? Yeah. In the past year, you've just seen Ozempic skyrocket.
Yeah. Yep.
And I'm just wondering some of
interesting story about that.
Yeah.
Go ahead. Get
no,
your
I was
question.
just gonna say it's just very interesting how it skyrocketed over the last year. You hadn't heard about it like really outside of the medical community.
Yeah.
Do we know enough about this? That we're going around taking shots and doing this stuff. And it could. You said nausea has a lot to do with some of this stuff that you're taking. I mean, do we know enough about this stuff?
They've been used for diabetes for quite a while. I would say in general they are safe. Now, do we know that they are safe in every patient who's now taking them who's not diabetic, who maybe has some other sort of issue? No, we don't know that yet, but the studies are ongoing. Are they perfectly safe? No. I put them in the safer realm of medications, though. What I was going to say is Novo Nordisk was the company that makes Ozempic, made more in the last year than the entire GDP of the country that they're in, which I think is Sweden.
Wow.
Mostly because of, they have other medications as well.
Because of
mostly because of Ozempic. Well, it's worldwide. People are taking Ozempic worldwide, so mostly just because of that medication.
So is it? Again, rabbit hole. We could talk about Ozempic for forever here.
We should do a whole podcast on it.
Okay, that sounds good to me. We're gonna have a lot of questions put on social media, but generally speaking, do patients have nausea while taking the medication?
A lot of them do, yeah. Typically what they talk about is on the front end, the first few weeks that they're taking them, they have quite a bit of nausea, diarrhea, just dyspepsia, discomfort in the stomach.
Yeah. And
then that gets better over time. But there is a pretty good evidence that weight loss for 4 to 10 to 20% of body mass or body weight is lost. And on top of that, your caloric intake just goes way down because you're just never hungry, from what patients say. Yeah, right. So that's a big part.
But you've got to stop that at some point, right?
People can take it for pretty long term.
Okay.
Diabetics have been taking it for essentially since it came out, consistently since it came out. There's maybe a little bit of effect on the kidneys, although it's not huge.
Sure.
Really, aside from that, we're not finding a lot of side effects from
even in
GLP.
like 25, 30 years of studying.
It's probably not been that long. It's probably been, I don't know, don't quote me on this, probably 7 to 10 years of studies, but in diabetics. But overall, relatively safe medications. And when you look at long term, one of the best predictors of longevity is low blood glucose levels.
All right, Brian, one more question before we wrap up this Q&A, and I remembered the question.
Great.
So, there's a lot of specialists in the United States and around the world, right? And if I want a specialist with cancer research or, thyroid or whatever, I'm going to hire or I'm going to go seek out that specialist.
Yeah.
Are anesthesiologists the same way? Like if I said, hey, I would like to hire you, Dr. Brian Schmutzler, as my anesthesiologist. Can I do that?
Yeah, it's a little bit different in the fact that we would have to be credentialed at that facility, right? So you're gonna go see a surgeon in an office, and you're gonna say, hey, best thymus surgeon in the country. I'll go to whatever hospital you're credentialed at. The problem is I want Brian Schmutzler as my anesthesiologist. Well, you gotta find a surgeon who comes to a facility that I'm credentialed at. So it's a little different, but
facility or state or both?
Well, both. Yeah.
Okay.
Licensed in and
sure,
and licensed in a state and then credentialed in a facility. So, but certainly, a lot of us who do a lot of different stuff are credentialed a lot of different places. So I've had people ask for me before to come to a facility that I don't generally work at, just to come do their case. And so that's a reasonable thing to do. But certainly, usually people travel or find a surgeon, and then anesthesia, we're sort of just there. A lot of us, though, are quite adept at certain areas of anesthesia just because of who we work with. So you would assume that the anesthesia provider who works with the guy who does a bunch of thymus surgeries has also done a bunch of thymus surgeries. So that's likely to occur as well.
All right. Well, I just wanted to see if I could bring you worldwide.
Yeah.
Mr. Worldwide, as they call you.
There we go.
Not Pitbull. All right. Well, again, another episode here. As we wrap up, you can find Dr. Brian Schmutzler on all social medias. Don't forget his Patreon page as well, and of course on YouTube now. And like and subscribe this channel. It helps him out, and of course helps get the word out about anesthesia and some of the topics that we're talking about. Dr. Brian Schmutzler, thank you so much.
Thank you.